Good evening, everyone. Thank you for joining us again for another webinar brought to you by New York Gastroenterology Associates. Just a quick introduction before we get started. I am Dr. Janie Yang. I will be moderating the webinar tonight. I am one of the 15 gastroenterologists in the NYGA group, New York City's premier private practice gastroenterology group. We provide consultations and perform diagnostic and therapeutic procedures for a variety of GI conditions. And we have 5 different locations throughout the city, from the Upper East Side to Brooklyn. Tonight, I have the pleasure of introducing one of our talented gastroenterologists, Dr. Ugo Iroku. Originally from the New York area, he received his medical training at Harvard Medical School before returning to New York City for his residency and fellowship at Cornell and Columbia, respectively. He is a proud member he's actually one of the founding members of the Association of Black Gastroenterologists and Hepatologists. And as tonight's talk will demonstrate, he is committed in educating the public by providing accurate scientific facts and combating health misinformation. You can find him on Instagram as Real Dr. Ugo or on his website, realdrugo.com. Before I turn the microphone over to him, just a couple of housekeeping rules and matters. So the webinar will be recorded and posted on our NYGA website, where you can find recordings of our previous webinars. The webinar itself will be about 45 minutes, and there will be 15 minutes left over for discussion and questions. And please use the Q&A function to submit any questions that you may have to the panelists. And our panelists, including Dr. Laura Fredo and Dr. Yevgenia Pashinsky, will try to address them. And we will address as many questions as we can at the end of the webinar as well. We aim to conclude this webinar at 8 p.m. today. So without further ado, let me turn the microphone over to Dr. Iroku.
Thank you, Janie, for that excellent introduction. Hello, all. Welcome to our webinar series. Today, we'll be talking about precancerous polyps and early onset colorectal cancer. So, I'd like you all to remember that your body is your greatest asset. Oftentimes, we take a lot of great care of our electronic devices, our phones, but we fail to take care of ourselves. And so I don't want you just to think about us as gastroenterologists tonight. I want you to think of us as colon tech support as we walk you through how to take care of yourself and to make sure your colon is functioning at its optimum capacity. So what are we going to learn today? We're going to learn what is a precancerous colon polyp. That's a phrase that some of you have heard sometimes, and we want to have a chance to just sit down and explain that to you, what that means. We're going to talk about what is early onset colorectal cancer. We'll talk about how you can lower your colorectal cancer risk. What is screening and when does it start? What symptoms should be taking you to the doctor? And what is your chance of beating this cancer? Now, we want to pause and say, you're going to have to change your mindset in terms of the way you normally process information. The goal of tonight is not just to learn new bits of information and facts. The goal is to understand that you have the power to affect your health. And as we go along, we'll just review different points where you can make an impact in your care, even alongside your doctor. All right, so what is a precancerous colon polyp? You can't talk about a precancerous colon polyp of the colon without starting to talk about the colon first. So what is the colon? The colon is the last stop on the digestive train, so to speak. And, we gastroenterologists are full of GI jokes, so just get ready for that. It's 6 feet long. It's also called the large intestine, the colon. It starts just above your right hip, swings up on the flank to your liver, swings around to the left and goes down again to just above your left hip, and then goes out below to the rectum, okay? And if you've ever heard that term precancerous polyp, let's just start by talking about what is a polyp itself. So on the inside of the lining of the gut, the mucosa, if there's a fleshy growth, we call that fleshy growth a polyp. And as you can see in this diagram here, your polyps can start off very small, turn to a mid-sized polyp, and then a large-sized polyp. And then eventually, that polyp can start having a very dangerous change in cell growth on the inside of the polyp, very undetectable. And then eventually, that cancer really grows into the bloodstream and beyond the gut wall. So this is the inside of the colon, and this is the outside. And so we call any polyp that has the ability to form a cancer a precancerous polyp. And so by definition, most polyps that we take out or that we talk about in the colon are precancerous polyps. So if you ever get that term, don't be too alarmed. That's the entire reason why we do colonoscopies in the first place, to take out those polyps, those precancerous polyps. And I'll highlight shortly which polyps are not precancerous, okay? So we can start off with a very common type of polyp called the tubular adenoma. This makes the bulk of the polyps that your gastroenterologist will see in your colon. With these pictures, we're just letting you in on our world, what we look at pretty much all day when we're inside of your colon. This is an example of a tubular adenoma. And what we normally do is we deploy a snare around this, a metal snare, a lasso of sorts, and cut that off and take it out of your body so that all the polyp is removed and you're left with healthy tissue. This tubular adenoma does have about a 2% or so malignancy transformation risk, which means that there's a 2% chance something like this can turn into a cancer if left there, okay? A slightly more aggressive type of polyp is called a Tubulovillous adenoma, little less common, sometimes has more flat appearance, and has a higher malignancy potential. And even more aggressive is a type called a villous adenoma, which can also have a malignancy potential that can approach 40% and is less frequent than the tubular villous and the tubular adenoma. So these are all adenomatous polyps. These last three types of polyps are all adenomatous polyps that we take out when we're in your colon. But there are other types of polyps that exist as well. There's this whole category of polyps called serrated polyps. And there was a time where we didn't know it was a big category, and we often lumped them all together as being hyperplastic polyps. Why is that relevant? Well, hyperplastic polyps usually do not have a malignant potential. And those are polyps that aren't thought to have the risk of forming cancer, at least not to the degree that the adenomatous polyps do. But what we learned over time was that those serrated polyps can come in different types. And so although hyperplastic polyps are the most common types of serrated polyps, there are other types of serrated polyps that do have a malignancy potential. So there are other types of serrated polyps that can cause cancer. Well, what does this mean? It means that if you have a pathology report that says you have a hyperplastic polyp, that's pretty much as good as it gets. In the inside of your colon, though, your doctor has to make sure that he takes it out, because he may not know whether or not it's a hyperplastic polyp or if it's a sessile serrated polyp or a traditional serrated adenoma, because they tend to look very similar. The pathologist may give further insight upon examination that one is one or the other, but for your gastroenterologist, we often will take these polyps out when we see them. All right, so those are the types of polyps. And now, what is early onset colorectal cancer? As all of us remember from receiving the news that Chadwick Boseman passed from early onset colorectal cancer, this is a disease that really does affect America greatly, not only because one of our great heroes who played so many iconic roles died from this disease, but it's a disease that's been around for many decades. If we remember, Katie Couric's husband, Jay Monahan, also died of early onset colorectal cancer over 20 years ago. And so it's a disease that's been around, that's affected us greatly. And we're going to look into it today and learn a little bit more about it. So how did we figure out that there was this separate entity called early onset colorectal cancer, where when we were looking at public health personnel, looking at the data and looking at how many people were getting colorectal cancer from the 1970s to current times, we found that there was a decrease in the incidence of colon cancer. So less people were getting colon cancer, less people were getting rectal cancer. There was a 30% or so decrease, and it was attributed mostly to our screening programs, mostly the colonoscopies, the FIT testing, et cetera, that we'll talk about shortly. But when we looked at the data a little closely and looked at younger people, we found that they were not having a similar drop in their incidence of colon cancer. Instead, since the mid-90s, the rate of colon cancer in young people has been going up to the tune of about 2.2% annually. And not only is the incidence, the occurrence of cancers going up in this population, but we also found that while the deaths are dropping in all adults, in this younger population, it's increasing there as well. So they're having more likely to get the cancer and more likely to die from the cancer. These are things that we learned looking at the data. And so as a means of definition, very simply, early onset colorectal cancer is defined as a cancer in the colon or rectum that is found in an individual less than 50 years old, okay? So one of the questions we ask ourselves is, well, what's the exact age breakdown of this early onset colorectal cancer? When along the spectrum is it occurring? And it turns out that in your 20s, the odds of you having a cancer is still very low. In this whole universe, in this whole 100% of people with early onset colorectal cancer, only 6% are represented as being 30 years or younger. But with every increase in 5 years, you can see that number going up. And that last bit of time between age 45 to 50, there's an additional 50% increase in the accumulation of colorectal cancer in this whole cohort of people having cancer. So the risk slowly builds up from early 20s, and by the time it hits the 40s, it's a rapid increase. What does this mean, though? It means that there are people, however, in their 20s and their 30s who are getting colorectal cancer. And so the myth that colon cancer is a disease of the elderly is one that we have to finally lay to rest. There was a time, again, where the average age of colorectal cancer was 63. And if you went to see your doctor, your gastroenterologist, your primary care doctor, they would often, kind of bypass a lot of the symptoms that you may have that might be concerning for colon cancer otherwise. But now you are empowered to know that you have to take those symptoms seriously because, yes, colorectal cancer can occur in the younger populations at a very lower incidence compared to the older early onset cohort, but still it's present just as well. All right, and so when we start looking at what part of the colon is involved in early onset colorectal cancer, which is a kind of a thing we think about, if you look here, the brown part represents the rectum, the green represents the sigmoid being the part right before the rectum. The descending is the part of the colon on the left side, and then the right colon is deeper into the colon all the way on the right. And what we see here is that early onset colorectal cancer is predominantly a left-sided, so a rectum sigmoid descending colon disease, predominantly. You can see that here. And if you look at the data a little closer, we see that about 3% of the time it's in the descending colon, it's early onset colorectal cancer. About 15% of the time it's in the sigmoid. 65% of the time it's in the rectum. And only about 17% of the time in this particular cohort that was done is the colorectal cancer in early onset colorectal cancer deeper into the colon on the right side. And so this is a disease that's predominantly located on the left, even compared to your typical colorectal cancers. All right. So another question is, well, how does early onset colorectal cancer do in terms of staging? And so there's a lot going on here, but if you just look at the deep blue first line in each stage, we can see very clearly that the most typical presentation for younger people is this stage 3. And so we find here that early onset colorectal cancer tends to be occurring at a more advanced stage at its diagnosis compared to late onset or more typical colorectal cancer. There are many reasons why that may be the case. One of them is just delay in diagnosis. A lot of times, again, when younger people are presenting with rectal bleeding or abdominal pain, it's not thought to represent a colorectal cancer. And so by the time they are diagnosed, there could be a more advanced stage. But now we're empowered to know that these symptoms can be important, and so we look out for that. And there's also signs that there might be more going on than just the delayed diagnosis. We also know that early onset colorectal cancer is a more aggressive type of cancer cell as well in general. So for example, if you look at this group, and again, there's a lot going on in this table as well, but on the left side, we have young people, 40 years old or below, and all the way on group 3, we have people age 51 and above, just to compare the two groups, group 1 and group 3. This is a particular type of histology type. So in other words, looking at this cancer under the microscope, this has the appearance of what we call a signet ring appearance, signet ring cell appearance. And in the parentheses, we see that in the early onset group, up to just about 9.6% of people have this more aggressive type. But if you look at people who are older, only 0.8% have this type. And so this is one of the many indices that show that early onset colorectal cancer tends to be a more aggressive type of tumor. Beyond just delay in diagnosis, it's more aggressive as well. All right, and so oftentimes people, when they think of young people with cancer, they imagine that this must be just a bad lottery, genetic bad luck, and that there must be a family history of cancer that would lead to a young person also having cancer at a young age. But what we find is that by far, the majority of people with cancers do not have a family history of colon cancer. 70% of them are sporadic, which is to say 70% of them, the individual with the cancer is the first person. So it's not a story they've heard from their mother, their father, their sister, their brother. They are the first person. And that is a very common and typical story. And so just because you have a family history that does not involve colorectal cancer does not mean that you are immune to colorectal cancer, okay? Now, 30% of the time, there is a family story of colorectal cancer, and 5% of the times, or actually 1/6 of those times, we're able to identify a specific type of hereditary syndrome, and the other 5/6 of the time, it's an unknown syndrome. But whether it's a known syndrome or an unknown syndrome, altogether, it only represents 30% of the time that there's this family history of colon cancer when a person is diagnosed. All right, so if it's not the genes driving these cancers, what is causing it? And the answer is, I'll tell you, we do not yet know, but there are a lot of very current work going into solving this very question. And it's thought to represent a lot of the exposures that we're exposed to, okay? Along 3 fronts. One of inflammation, the inflammatory process in the gut. For example, people with Crohn's disease or ulcerative colitis, if you have an inflamed bowel, it's thought to put you at greater risk for colorectal cancer. That's why controls are important, because less inflammation is shown to likely correlate with less likelihood to develop the polyps that would develop cancer. All right, but beyond inflammation, there's also obesity and diabetes. And these are some strong associative factors that we see in colorectal cancer that are being examined. Nothing is a slam dunk yet in terms of causative proof yet. Obesity, there's some arguments for and against, and we'll look into some of that data in a little bit. But one step before this inflammatory process, the obesity and the diabetes, is the microbiome, like we talked about 2 webinars ago. And there's a lot of things that affect our microbiome and affect essentially the state of your colon. One of them is the global westernization of the diet. So this effect of other onset colorectal cancer, it's something that's being seen globally. And the thought is that as other countries have a diet that's more similar to ours, they're experiencing a lot of the exposures that we are. What are some of these exposures? Unhealthy cooking practices. Char grilling is one of those. An unhealthy high percentage of red and processed meats. Synthetic dyes in our food. MSG, titanium dioxide, a thickener, a sweetener used, and high fructose, so corn syrup also used as a sweetener. These are some of the toxins that might be affecting our bowels, and there's a lot of research looking to see if these are the reasons why we are having early onset colorectal cancer at such a high rate. All right, and so looking into obesity, it's hard to not suspect it. We already knew, even before, for many decades, there's been a steep rise in obesity amongst the youth and young adults in this country over the past 2 decades. And so this curve in some ways mirrors that of early onset colorectal cancer. And so the question is it related? So beyond just temporal correlation, we look for geographic correlation as well. And this graph is looking to show you which states in the United States of America tend to have more early onset colorectal cancer. And so those that are in red or orange are the worst hit states. And these tend to be in the Midwest, in the southern states. And New York is around the middle in terms of getting colorectal cancer. And then when we look at mortality, dying from colorectal cancer, it's a similar story. The highest numbers tend to be located in the Midwest and in the South. And so is there anything that we can learn from this distribution? Are there any exposures going on in the Midwest and the South compared to some of the other regions in America that might give us more insight on the reasons why early onset colorectal cancer exists? Well, one, again, is obesity. We do find there is this correlation of the distribution of obesity along, again, some of these geographic lines as well. That when people report not consuming at least one fruit a day, this also seems to correlate geographically. When people report not consuming at least one vegetable a day, that same distribution we see. And when people report not having leisurely time, not having physical activity, again, it seems to correlate. And so these are some of the reasons why these are things we're looking into in terms of potential reasons why early onset colorectal cancer exists. There will be a lot more to come on this topic in the years to come. So the question is, what can I do as an individual to lower my risk? All right. And so we're going to examine some of these. So looking at obesity and diet, you might hear us talk about processed meat and red meat, that these are things that we're supposed to avoid. And so I wanted to make sure we spend some time talking about what these actually look like. So what are processed meats that have been, they are meats that have been transformed through the salting, the curing, fermentation, smoking, and other processes that enhance the flavor and improve preservation. Pretty much if it can hang out in your refrigerator or your home for weeks without end, it's a processed meat, okay? And so these include things like hot dogs, sausages, ham, beef jerky, corned beef, canned meat, meat-based preparations and sauces. These are processed meats, and unfortunately, they correlate with the higher rates of colorectal cancer, and these are some of the items that we're supposed to cut down on. So what are some examples of red meat? These are mammalian muscle meat, so items like veal, beef, mutton, goat, pork, lamb, and if you're so inclined, horse. And so if you needed yet another reason not to eat horse meat, this graphic is one of them. You need to cut down on red meat. What's a preferred diet? The Mediterranean diet would be an example of that. That has much more fruits and vegetables, oils in a proper amount, fish and seafood, eggs, cheese, poultry, yogurt, and then a small amount of red meat and sweets as well. Okay, and some daily servings, of course, allowed of whole grains, bread, beans, pasta, and nuts. So these are some examples of a more healthy diet that you can have. As we talked about with Tamara, the key is diversity of your foods and making sure you're eating a lot of different types of foods and not just sticking to one particular type and doing that repeatedly. All right, so what are some other risk factors that we can change? What are some of the other modifiable risk factors? Well, one of them is smoking. And no surprise, we all have a concept pretty strongly in our culture that smoking can cause lung cancer. We're also perhaps that it can cause cardiopulmonary disease as well. Well, it can also cause colorectal cancer, unfortunately. And long-term smokers have a 30 to 50% greater risk of colorectal cancer. So when you stop smoking, you're not only helping your heart and your lungs, you're also helping your colon, and just to many other parts of your body as well. All right, so what about physical inactivity? What does that mean? What role does it play? How big is that problem in America? Well, it turns out that if we did the physical activity that we're supposed to do, making sure you're breaking a sweat for at least 30 minutes and doing that most days of your week. Some people shoot for all days of the week. Some people shoot for 4 to 5 days of the week. If you did that, you would prevent 1 in 8 cases of breast cancer, 1 in 8 cases of colorectal cancer, 1 in 12 cases of diabetes, and 1 in 15 cases of heart disease. You'll frequently hear a lot of your doctors telling you the same thing: exercise, eat right, and limit things that are harmful, like smoking. And that's because these inflammatory effects don't just affect one system, organ system, they affect your whole body. And so, yes, physical activity actually does help your colon cancer health as well, and decreases your risk of colorectal cancer. All right. And we find that only 1 in 4 adults fully meet physical activity guidelines for aerobic and muscle strengthening activities. And so the other 3/4 of us need to get on board, because that is life-saving on a number of fronts. Okay. And then in terms of diabetes, it is known also, again, diabetes has been associated and relates with a lot of cancers that occur in the body, liver and pancreas, but also colon cancer. There is that connection as well. And so the better we are about taking care of our diabetes, or if you're pre-diabetic, making sure you're eating right and to lower your risk of having diabetes, the more we do that, the less likely we are to have colorectal cancer, okay? And then lastly, in terms of modifiable risk factors, these things that we can change, is alcohol. So it's sometimes it's a tricky thing to try to take a person's beer from them, or a glass of wine, but this is the reason why we come after your alcohol at times. So alcohol, when it's processed appropriately, forms acetaldehyde and eventually forms acetate, which is actually an energy source that's good for the body. However, when we drink in a large amount, we produce too much acetaldehyde for this whole system to handle, the funnel effect. And so there's an outpouring of this acetaldehyde in the system, so to speak, which can cause damages in your DNA and eventually lead to situations that can cause colorectal cancer. So when we're picking on you, and your gastroenterologist is picking on you in terms of limiting your alcohol intake, this is the reason why. The acetaldehyde can actually help increase the risk of colorectal cancer. All right, so that's why we mentioned that. All right, so one question you might have is, well, what is this whole screening for colorectal cancer system? When does it start? How do I know when I'm supposed to jump in? And so I just wanted to start by saying 60% of colon cancer deaths would be prevented with regular screenings and early detection, okay? So if we all knew when we're supposed to get screened and adhere to it, 60% of the cancers that we have in this country could be presented. That's a very stark number, okay? And it's especially important because the frequency of colorectal cancer is very frequent. We all have a lifetime risk of 5%. So in other words, 1 in 20 of us will be diagnosed with colorectal cancer. It's that frequent. Every year, there's about 150,000 people diagnosed with colorectal cancer, and there's about 50,000 deaths a year. And so screening is important. All right, so to start with screening, if you're having symptoms, you're not even in the screening category. Screening refers to people who do not have symptoms. And so if you're having symptoms, you should talk to your doctor immediately, right? But if you have some of these other risk factors that are not modifiable, you may not be able to modify your family history, your race, whether or not you have a genetic predisposition to cancer, whether or not you have a personal history of cancer. You may not be able to modify whether or not you have ulcerative colitis or Crohn's, but what you can do is modify your screening frequency. And that's the way we approach the non-modifiable risk factors for colorectal cancer. We modify the screening. So what is screening? Screening means we look for the colorectal cancer before you have symptoms. We're looking for either the cancer or the polyp. If we see the cancer, we send you to surgery to have that taken out. If we see the polyp, we take it out ourselves during our colonoscopies and relieve you of the risk of forming the colorectal cancer. All right, so just to jump into the weeds a bit in terms of family history, when we talk about family history in colorectal cancer, we're mostly talking about father, mother, brother, sister, that immediate nuclear family. If you have a family history of colorectal cancer, you should be screened at age 40 in general, or 10 years before the youngest case in your immediate family, okay? If you're African American, the screening age already has been proposed as being age 45. You might have heard that the United States Preventive Service Task Force is making early signs that perhaps by summer of this year, they'll be moving the screening rates of all Americans down to age 45. And so 45 is going to be the new 50. Screening doesn't start at 50 anymore. Screening will start at age 45. And a lot of practitioners use that number anyway. And there's some people who feel that African Americans should start their screening at age 40. Either way, this is to say, have a conversation with your doctor if you're African American, because African Americans have a 40% higher likelihood of dying from colorectal cancer compared to Caucasians, and a 20% higher likelihood of getting the cancer. And so if you're African American, make sure you have a conversation with your doctor as well in terms of your particular increased risk of having colorectal cancer. Of course, if you have a genetic link to genetic disease in your family, if you've heard the terms Lynch syndrome or familial adenomatous polyposis in your family, then you have an increased risk of colorectal cancer as well. And that risk is even greater than that afforded or that's given by having a general family history or being African American. And they tend to start their screening much earlier, around their early 20s, or 2 to 5 years younger than the youngest person who had it. And they have it repeated pretty frequently, every year or every 2 years. Either way, if you have such a history in your family of having one of these genetic predispositions, make sure you have a conversation with your doctor about early screening, okay? If you have a personal history of cancer, make sure you talk to your doctor. And again, like we mentioned before, if you have a chronic inflammatory state like ulcerative colitis and Crohn's disease, you have a higher risk as well, especially if it involves a lot of the colon, especially if it's frequently inflamed, and especially if you've had it for a long period of time, 7 or 8 years or greater. These are things that should prompt you to have a conversation with your doctor. These days, we're being very aggressive to make sure that we screen our patients who have IBD to make sure their risks of colorectal cancer are taken as low as possible. All right, and so I did want to take a time just to pause to give thought as to how COVID-19 has affected our colorectal cancer screening. We found, no surprise, that with the coming of COVID-19 to New York City and across the country, that there was a 90% drop in colonoscopies compared to a similar period in 2019. That goes along with, or correlates with 18,000 missed or delayed diagnoses. 1.7 colonoscopies did not happen. And what we're afraid is that that means that over the next decade, we're going to see over 4,000 more deaths than we needed to see, or that we would have seen if not for COVID-19. So COVID-19 and the effect that it had on our healthcare system is stark, and unfortunately can result in excess deaths if we're not aware of it, and if we don't snap back and kind of make sure that we're all getting our screenings in our family and in our communities. All right, for communities that already have inequities, COVID-19 caused pauses in a lot of underserved populations. There were almost 2,000 healthcare centers that were shut down over 2020 and 2021. And what we find is that it's not easy enough to just say, well, everyone can access their doctor, just put up your laptop and get through to your doctor, so there shouldn't be a barrier. What we find is that 1 in every 4 Americans lack the digital literacy or the skills or access to get internet-enabled care. And so although many of us have the privilege of being able to access our doctors, many of us can't. And so it's a big public health issue. In terms of just looking at 63% decline in healthcare center visits, and the fact that measures are in place to reduce the risk of transmitted COVID-19 caused the drop in people having access to their doctors, compounded the whole issue. And what we find is that it's not only issues that occurred in the past, but because of the financial impact of COVID-19 on our economy, there are about 25 million people who are estimated to lose their employer-sponsored healthcare insurance. And 80% of primary care providers report that their patients are struggling with virtual care. And so there is a past and ongoing effect that COVID-19 occurred. And that means we have to be hypervigilant as to how to address it in ourselves and in our communities. All right, and so luckily there are options, right? And so the primary option that you'll hear about is the colonoscope. And this is where, under sedation, the gastroenterologist will put a lighted scope and look through your colon to take out any polyps. It can prevent cancers because we take out the polyps before they have a chance to form. It's done either in the hospital or in the ambulatory surgical center, or in some cases, office-based procedure centers. And it's usually done every 10 years. However, if you do have polyps that are found, we bring you back sooner. And that all depends on your doctor's opinion as to what's going on. In some cases, we may bring you back in 7 to 10 years, in some cases 5 to 10, in some cases 3 to 5, in some cases 3 years. And some people even need to come back the next year or in 6 months. It all depends on the details of what your doctor saw, okay? But there are other options as well that exist. There's FIT and there's FIT DNA. So FIT refers to the term fecal immunochemical test. And all this is a test to see whether or not there's blood in your stool. And so what we're saying is that there is a way that you can do colorectal cancer screening in the comfort of your own home by doing the FIT test. The disadvantage is that it can't present the cancer, but if the cancer is there, it'll detect it. Now you may say to yourself, well, if it's only detecting the cancer, why is that any good? The reason it's good is that early detection matters. If we detect colorectal cancer in stage 1 form, you have a 90 to 95% 5-year survival rate. But if you don't detect it, if you wait until stage 4, then that rate of survival drops to the 15%, which is still significant, and people do win and survive this all the time, but it just makes for more work and more work that the survivor has to go through. And so FIT and 15A testing is very useful because it helps for early detection. Because of the nature in which it's being done, it does need to be repeated much more frequently than your colonoscopies. FITs can be done every year, and FIT DNAs can be done every 3 years if the original was normal. FIT DNA refers to the fact that not only you're looking for the blood in the stool, but you're also looking for any genetic cells that suggest there might be a cancer in the stool as well. All right. And so next question that we frequently get at New York Gastroenterology Associates are, what symptoms should bring me to the doctor? Sometimes people come in to see us and they're embarrassed because they're talking about bloating and flatulence and belching, and they don't want to be there talking about these symptoms, but maybe their spouse, their mother, their son, their daughter dragged them to come in. And so what symptoms that really should be bringing you to the doctor? And so these are the things that we see that occur very frequently in people who have colorectal cancer. So we can talk through some of these. Change in bowel habits is just one of the most common ones. When it comes to constipation, it's about on the order of 50%. When it comes to diarrhea, about 33% of people with colorectal cancer will have diarrhea. Now, as you already know, almost everyone gets diarrhea, almost everyone gets constipation. And so it doesn't mean that everyone who has constipation or diarrhea needs to go to see a gastroenterologist that day. However, what this does bring into mind is that everyone has to know their body. You have to know what's normal for you. And if you know that all your life you are someone who goes to the bathroom every other day or 3 days a week, and now you're going every day or multiple times a day, that's different for you. And if that persists, beyond a day, a couple of days, a couple of weeks, a couple of months, you should talk to your primary care doctor and perhaps a gastroenterologist about this. Or if you're the other way around, where all your life you've been going 3 times a day, and now you're going just a couple of times a week, you should talk to a gastroenterologist because there might be something else going on, and we can help you figure it out. You don't have to figure it out on your own. You don't have to be both the patient and the doctor at the same time. All right. So bleeding from the anus, this is something we also see. About 15-20% of patients who see blood coming out, and oftentimes they attribute it to hemorrhoids, same thing as seeing blood in the stool. And oftentimes it's right. Most of the time it will be external hemorrhoids or internal hemorrhoids. However, if you've done all the right things and you fixed your constipation, you're having a high fiber diet, a lot of fluid, 8 glasses of water a day, if you tried the topical preparations, the cortisone preparations to reduce the hemorrhoids, and you're still having bleeding, you should bring this up with your primary care doctor or even your gastroenterologist to ask about further next steps. Sometimes what we do is to check your blood to see if there's signs that you're anemic. And if there's signs that you have been losing a lot of iron and you're anemic, it might be a sign that this is more of a prominent problem than you thought before. Bloating is very common, again, in the 50% range. So 50% of people with colorectal cancer will have bloating. Why is that the case? Again, it's because these growths tend to grow on the inside of the colon, sometimes causing obstruction, sometimes causing pain, affecting the pain nerves. And people can have bloating and pain and discomfort. It's a very common symptom. even people with colorectal cancer and people who don't have colorectal cancer. Again, a conversation with your doctor helps you tease apart what's benign and what's serious. If you have a loss of appetite, especially to the point where you're having unexplained weight loss, definitely have a conversation. This is definitely a red flag. We want to know about that. And if you're persistently lethargic or you're looking pale or jaundiced, we want to know about that as well. All right. And so we're going to wrap up with just the conversation of what are my chance of beating colorectal cancer. The good news about colorectal cancer is that not only is it preventable, but as cancers go, it's one of the more treatable and beatable cancers. All right. And so we know that 7 out of 10 people diagnosed with colorectal cancer have no symptoms. And so what we want to do is we want to diagnose the colorectal cancer before you have symptoms. So one way to beat colorectal cancer is to make sure you're getting your screening, okay? We want you all, again, if you have the family history, to make sure you're getting your your colonoscopy screening 10 years before anyone else who had polyps in your family, or have the conversation as to whether or not there is a family history. Sometimes we don't know. Most people do not know their family history. And so this should be an impetus to feel empowered, feel deputized, to just start asking everyone in your family about their colon health. And so we can find out if there's a family history you need to respond to. Because when you find colorectal cancer before there are symptoms, you have half the chance of there being an invasive tumor. You have half the chance of it spreading to the lymph nodes, which is stage 3. You have a third of the chance of a distal metastasis, which is stage 4. And you have a third of the chance of cancer death, okay? And so again, we find colorectal cancer, when we find it at the various stages. You know, is it at a stage where it's still within the lining of the colon? Is it in the stage where it's gone beyond that and entered into the muscle? Is it in the stage where it's hitting your lymph nodes? And is it a stage where it's gone beyond your colon to distant organs through your body? We want to diagnose people in the stage 1 category. So we want less stage 4, less stage 3, less stage 2. How do we get there? We get there by people talking about their colon health to their family members, talking about diseases in their family members, sitting down at the table and talking about their colons, about their symptoms, understanding if they're their family history, because that understanding will get you screened earlier. Also, if you have symptoms, that understanding will let you get your colonoscopy before it's even time for screening, because once you have symptoms, sometimes you need a colonoscopy right away. All right, and so again, what we know, like I said before, blue is stage 1. And when we find colon cancer or rectal cancer in an early stage, the odds of survival are excellent. Okay, that's over here, the blue over here. And what we want to avoid, again, is waiting until a much later stage where the odds are beatable, but with more of a fight. Okay, we want to definitely push things to more of a stage 2 and stage 1 diagnosis. Again, we get there by conversation, knowing your family history, talking about your symptoms with your doctor, getting screened before you have symptoms, right? So this is a bit of trivia, but Charles Schultz himself passed of colorectal cancer. He was the beloved creator of Snoopy and the gang, Peanuts. And so, as he would say, you can make a difference in your colorectal cancer health and in that of your loved ones as well. All right, so at this point, I'm going to bring back our moderator, the capable Dr. Janie Yang, and field some of your questions.
Hello, that was wonderful. Okay, we have a lot of questions coming in, so I'll just jump in. So one of the first questions we receive is regarding genetics, and how does genetics play into someone developing polyps or colon cancer in general? I think you kind of mentioned it about first degree family member. What about uncles and aunts and some more distant relatives?
Yeah, and so I'll get you back to this screen here, and then I'll talk about it. But long story short is that in terms of what it's doing, we have genes in our body whose job is to make sure that your cells are behaving, that the DNA is accurately being passed on the information from one cell to the next cell. When those genes stop working, mistakes are made in the copies of our cells. When those mistakes are made, that forms cancer. So on a genetic level, there are these copywriters. There's this editing function. And when the editing function goes off, that's what causes cancers. Now, how does that play itself out? Now, most of the time, it's not a syndrome we know about that we can put a name to. There was a time, again, where we were confident and we thought, well, yeah, we can figure out who has Lynch syndrome or who has, one of the other syndromes. But right now, we realize that a lot of these syndromes, we don't know the exact syndrome going on. But with careful family history taking, we find out there might be an uncle who had a young cancer. So if you start hearing the word young, so people having cancers before age 50 or 40, if you start seeing people who had multiple cancers in the family, if you start seeing people in your family who have unusual cancers that, like endometrial cancers or cancers that you don't tend to hear about as much, these are some of the clues, perhaps, that there might be a familial, a genetic process going on. There may not be a name tag to it, but it's important to bring it to your doctor, and we'll help you figure out what your risk is in the process.
Yep, that is very true. And I think it's whenever we speak to a patient, we always try to ask as much as we can regarding their family history of cancer, any kind of cancer, not just colon cancer specifically, because there are definitely hereditary syndromes out there that includes colon cancer as part of the category of other cancers that they could also develop. And then sometimes when we find patients with multiple family members with bizarre cancers, we can actually involve the medical genetics team as well to kind of go through these kind of cancers and kind of determine, is there something hereditary in your family that puts you at a higher risk of developing certain kind of cancer? It may not be colon cancer, it could be cancers of the other GI tracts, like the pancreas, for instance. But that's another specialist that could potentially be involved in your care as well.
Yeah. And the reason why that's important is that you may not be able to prevent that first cancer that occurs that rocks you or your family, but you have a shot at preventing that second cancer. And so when you ask those questions of your family, you are putting your family on the offense, and you're getting your family the offense to do their screening, not just of the colon, but there is a lot of screenings that could occur in the other parts of your body where you can take out that other cancer that would have occurred, but now it won't occur because of your diligence.
Right. And you're involving other family members as well, not just maybe potentially your siblings and even your children could need to be screened much earlier as well.
That's right.
All right. So another question I have is regarding diverticulitis and colon cancer. Is there a correlation between the two? If someone were to have diverticulitis, what should they do regarding colon cancer screening?
Yeah, so in general, I wouldn't say there's a strong diverticulitis colon cancer correlation. What I would say is that not to the degree that it would change any management. People with diverticulitis have a more acute problem. So for those of you who don't know, diverticulitis is what happens when your diverticulosis is inflamed. And what is diverticulosis? Diverticulosis are little dimples in the colon that sometimes can get inflamed, cause a lot of pain, need antibiotics to get those under control. So when a person might have one episode of diverticulitis all their life, and so there's not a prolonged inflammatory state per se with that. If you have 2 episodes of diverticulitis or 3 or 4, and it becomes more frequent, Unfortunately/fortunately, we don't leave it in there for it to cause a long-term problem. Frequently, we start telling you to have a conversation with the surgeon to take that part of the colon out because there's a risk that that area of the colon could have a perforation. And so we oftentimes don't leave you in a chronic inflammatory state with diverticulitis. Now, every now and then people do have chronic appendicitis or colitis, and we try to figure those out ASAP. But most typically with diverticulitis, it's not a long-term, day after day inflammation the way it is with Crohn's ulcerative colitis.
That's very true. And another thing I find interesting is that a lot of times we diagnose diverticulitis by doing a CAT scan. And the CAT scan shows there's an area in your colon that appears inflamed, but oftentimes the radiologist will say, it looks like diverticulitis, but they can't completely rule out something bad like a malignancy there because the whole area just looks so bad and inflamed and thickened. And that's another reason that once you've had an episode of diverticulitis, you may and potentially should get a colonoscopy just to make sure that area there's nothing else really is there.
Yeah, definitely should, and this is one reason why always make sure when you talk to your doctor, tell them your symptoms, don't tell them your diagnosis. Don't say, I have diverticulitis. Say you have pain in the left lower part of your abdomen, and let your doctor and your primary care doctor think through it with you, because it could be something else, and we want to make sure there's nothing else than just diverticulitis.
Right. All right. Let's see. Let me see what other wonderful questions we have. Okay. And then one good question: at what age we should stop doing colon cancer screening? And that's a tough question.
It is a tough question, but I think in general CDC guidelines would have a screening going from age 50 to 75 or 45 to 75, but as an absolute. And then once you hit past 75 and you're in the 75 to 85 range, then it's more of a conversation with your doctor. And so, we all know in our families, there are some people who are 85 and they can run laps around all of us. And there's some people who are sicker and more immobile and not able to go through with the laxative preps and just do not desire to do those aggressive procedures. And so it really depends. Once you hit age 75, it's more of a conversation. And then once you hit age 85, that's when we tend to say, okay, no more screening. Even if you wanted to do screening, we don't do screening. However, oftentimes if people have symptoms, even past age 85, and if they're healthy enough to get the procedure and do the anesthesia, we will do a colonoscopy, not for screening, but to look at the symptoms going on. Again, screening is when there's no symptoms and we're taking a look. And when you have symptoms, that's a different reason to do colonoscopies. And we will frequently do that, even in people, even their 90s sometimes. If they're young and healthy and having symptoms, sometimes we'll take a look to make sure we know what's going on.
Right. And then in one of the diagrams, you talked about the colonoscopy, the FIT testing, and the Cologuard. Where do you think something like a virtual colonoscopy or virtual colonography on that diagram?
That's right, exactly. So we simplified the diagram just not to confuse everyone, but there are many amazing options when it comes to looking at your colon. And the option that Dr. Yang is talking about is a virtual colonoscopy. So what is it? It has some aspects of the regular colonoscopy and some aspect of just a regular CAT scan. So you do have to drink a prep. You do have to go in. There is an insertion of a tube into the rectum to help the radiologist, put air into the system so he can get a good look in. But you also you're there and you're not receiving any anesthesia because they're not going entirely through your colon. And so for people who are afraid about anesthesia, it's a good option to take a look, but without putting you through the actual passage of the scope through your whole colon. And so it's one of those options that has a pretty good test characteristics. So sensitivity for medium-sized and large polyps. It's not as good as finding the smaller polyps in the colon. And if we find anything, then we still have to do a colonoscopy to take out the polyp that the virtual colonography or CAT scan shows. But it's there. It's useful, a test, again, for people who would like to avoid sedation if possible.
Right. And again, I think in my opinion, at least, I think colonoscopy is probably the best test both as a screening test and a therapeutic modality, because it really, compared to all the cancer screening tests out there, a colonoscopy is truly the best one, because it can not only detect things, it can also remove polyps that can potentially become cancer down the line. So you kind of get rid of that risk right from the beginning. And
that's right.
No screening tests out there can do that.
And of course, the best test is a test that gets done. We definitely understand and agree with that. But yeah, for the reason why you said it, and for example, when people have an increased risk of colorectal cancer, if they're having symptoms, or let's say with ulcerative colitis or Crohn's, there isn't an option of just doing a FIT test. You have to do a colonoscopy as you're screening. And so there are situations where clearly the colonoscopy offers advantages that the stool test, FIT test, or the stool FIT DNA doesn't offer. That's true.
All right. And another question that's interesting as well, aspirin. What are your thoughts about using aspirin as a preventative measure?
Yeah, so aspirin is definitely one of those agents that's been out there. So for those of you who wonder why we're talking about aspirin when we're talking about cancer, there's this concept again that inflammation ultimately can lead to situations that cause colorectal cancer. And so any agents that calm down inflammation in the body might be able to decrease your risk of colorectal cancer. And there's some early data. It's not definitive, but there's some data that shows that medications like aspirin may have that effect. It's one of those things that's not yet a common practice, because aspirin in and of itself has its own risks, benefit ratios that you have to consider. And so again, people with aspirin may have increased risks of bleeding, stomach ulcers, GI symptoms that can complicate a lot of the screening we're trying to do. And so we'll see ultimately where the science leads us on that front. But as of now, in terms of national general recommendations, there is not a mandate of using aspirin to reduce colorectal cancer in all patients.
Great. I agree. My thought about aspirin is there's no clear evidence about it as well. And I do warn people about the potential side effects from taking aspirin, because it can definitely lead to things like stomach ulcers, which is one thing that you don't want in preventing getting colon cancer, essentially. Another question that I have, give me a second. Let me see. If you were to detect a polyp during a screening colonoscopy, how does that translate into your risk of developing colon cancer down the line?
Yeah, so if you have a history of colon polyps as detected by your doctor, in our minds, you've gone from the general pool of risk, everyone who has a risk of having colon cancer, to a slightly higher risk. Now, this doesn't mean you're going to get cancer. It just means that we screen you more frequently. That's how we change any risk factor we can't modify. Any risk we can modify, we change your screening. And so because you have that slightly higher risk, the way we address it is that we bring you back sooner. And so if you have, 1 to 2, let's say tubular adenomas, we might bring you back in 7 to 10 years. If you had a large polyp, we might bring you back in 3 years or 3 to 5 years. If you have a sessile serrated polyp, which is a different type of polyp, we might bring you back in 5 to 10 years. So it all depends on the polyp we see. That'll determine exactly when we bring you back. The type of polyp makes a difference. The number of polyps makes a difference. The size of the polyps makes a difference. And yes, we handle that risk for you by bringing you back sooner. So when your doctor tells you to come back in 3 years, don't get mad at us. We just love you and want to keep you around.
Very true. Very true. All right. Let me see if there are any other. Here's another good question. You mentioned that avoid excessive alcohol is very important, but what about moderate drinking? 1 or 2 a day, perhaps?
Yeah, so it's always going to be a great question, and always a moving target over time. As of now, yes, a drink, no one's going to take your drink a day from you. That's still considered okay. But it's one of those things, again, as you know, there's a lot of things to consider. Can you keep your drink down to just a glass a day? Because there's some people who are dealing with the very real issue of alcoholism and alcohol dependence. And so although there are many factors at play, in general, yes, moderate amount is fine. Excesses, not fine. And we'll leave it at that for now.
That's good. Yes, everything in moderation is what I always tell my
Everything in moderation.
All right, let me see if I can.
Well, not everything, but some things.
Most things in moderation is always the best answer. Can early onset colorectal cancer present without polyps?
Yeah, so fascinating question. So most cancers occur through the polyp sequence. There are some situations where people can develop cancers without going through either what we call the tubular adenoma or the adenomatous polyp sequence or the serrated polyp sequence. I'm going into jargon now, but I apologize. You asked a technical question. And yes, like say, for example, people with ulcerative colitis or Crohn's disease, sometimes they can be at risk of forming a dysplastic lesion that can form a cancer without going through those more traditional pathways. So the short answer, simple answer is yes, it's possible. But the good news is that it's not at all typical. Usually colon cancers will present first as a polyp that you will have an opportunity to take care of if you take your colon to your gastroenterologist.
Right. And again, I think early onset colon cancer is such a hot topic right now. And it's one of those things that oftentimes we as gastroenterologists, we find people who we try to detect early onset colon cancer as early as possible, obviously. But a lot of times people don't initially come to us with a lot of these GI symptoms with early warning signs. And they often go to their primary care doctor who may not be aware of the fact that early onset colon cancer is actually a thing. They may give you hemorrhoid cream and treat the hemorrhoids for a long time and keep telling you it's just hemorrhoids and hemorrhoids, but in the end, they may be missing the sign for early onset colon cancer. So that's, again, it's for patients, for all of you to be aware of that so that don't miss the sign, essentially. Because
that's right. If there's one take-home lesson, it's the myth that colon cancer is an old person's disease. Let's be done with that. It can occur. The youngest person I've ever diagnosed was in their 20s, early 20s. And so it can occur in a very young age. Luckily, it's very rare, and that's great. But again, you don't have to be the doctor and the patient. Talk about your symptoms with your doctor. And if you feel you're not being heard, find a doctor who will hear you and make sure, again, it's one thing to have symptoms for a month, 2 months, 3 months, but if it's lingering, not getting better, you can plug in. And just so you know, there are people who've had years of symptoms get diagnosed with colorectal cancer, and they do fine. They get their surgery, plus or minus chemotherapy if necessary, and they beat the disease. So people still beat the disease even after years of symptoms. So don't feel like if you've had your symptoms for years, you're done for. You're not. It's still a beatable disease.
All right. I think that wraps it up. It's 8 o'clock. And I just want to thank everybody for joining us tonight. And again, this whole thing is being recorded. If you want to rewind, rewatch, feel free to do that. It will be posted on our website. Any last word, Dr. Iroku, before we sign off?
Thank you for joining us today. We look forward to taking care of you further at New York Gastroenterology Associates.
All right. Have a good night, everyone.
Take care.